Yeah, so you raised quite an important point there that ADT and perhaps even treatment intensification with the use of an ARPI agent leads to a substantial increase in cardiovascular events and perhaps cardiovascular mortality. And in last year we published a JAMA Oncology paper showed that this risk might even be doubled with the addition to an ARPI with ADT. And this really highlights the need to managing patients more holistically beyond just the oncological endpoints that we look at and offering these patients better management of the toxicities associated with it, covering bone health and cardiovascular health in particular. An approach here might be that we monitor patients for risks of developing cardiovascular events, and these could include the risk of the presence of baseline hypertension or diabetes, and in these patients in particular we need to take a more aggressive approach in managing cardiovascular risks, which could be either the use of primary prevention with the use of beta blockers or calcium channel blockers for managing their hypertension, or keeping a close eye on them for risk of developing diabetes and treating them preemptively with good glycemic control. In the longer term, these sort of approaches have been shown to reduce cardiovascular events, and it might be in more complex cases that we might need to work more closely with cardio-oncology colleagues, and perhaps in the simpler cases work very closely with community care physicians to manage their cardiovascular risk profile and reduce these adverse effects in the longer term. Yeah, so we presented data from the STAMPEDE Metformin trial focusing on the M1 patients, where we randomized about 1,800 patients to receive either standard of care therapy or standard of care in addition to metformin, which was continued lifelong amongst the patients with metastatic disease. The primary outcome of the study was overall survival, but a key secondary outcome was metabolic effects, which was the focus of my presentation today. The primary outcome of overall survival was reported at ESMO last year, and this showed that in an unselected population there was no statistically significant effect of the adding metformin with a hazard ratio of 0.91, but amongst patients stratified using a pre-specified but not pre-powered analysis based upon metastatic disease burden, we found that the effect of metformin was again not significant, with a hazard ratio of 1.0 amongst patients with low volume metastatic disease, but amongst patients with high volume metastatic disease as defined by Charted, there was a significant benefit with the addition of metformin with a hazard ratio of 0.79 if I remember correctly. And this translated into a roughly 10-month improvement in overall survival for patients with high volume disease who have the most aggressive disease characteristics. So today we presented the metabolic effects of the addition of metformin, and this is really targeted on the fact that ADT, as I mentioned earlier, can increase the risk of cardiovascular events, but also increase the risk of developing diabetes, weight gain, and hyperlipidemia. And we found that amongst patients recruited to the Metformin M1 trial, a lot of these adverse effects were reduced. So weight gain was lower amongst patients who received metformin in addition to standard of care therapy, of about 2.5 kilograms compared to 4 kilograms amongst patients treated with standard of care alone. Waist circumference, the increase in this was lower in patients treated with metformin. Glycemic control was better. Total cholesterol and LDL cholesterol levels were lower amongst patients treated with metformin, and intriguingly and perhaps most significantly, the incidence of patients going on to receive to develop metabolic syndrome was 9.4% in the patients on the standard of care arm and about 4.9% in patients treated with standard of care plus metformin. So overall, this would suggest that the addition of metformin to standard of care therapies might reduce or mitigate the adverse features associated with long-term androgen deprivation therapy. Yeah, so you're absolutely right. So about 85% of patients recruited to the STAMPEDE M1 metformin trial the standard of care was ADT plus docetaxel. And following a pause during COVID, when recruitment recommenced, the standard of care had changed to ADT plus an ARPI agent. And I think there's roughly about 50 or 54 patients on the Metformin trial who did receive that more recent standard of care of ADT plus ARPI. In terms of what the results mean, and I guess the only way we would know for sure is if we were to continue this trial and recruit many more patients with ADT plus ARPI. But what it's reassuring to find is that we already know the side effect profile of long-term ADT. Even with a ADT plus ARPI doublet backbone, ADT will continue to have this the side effect profile, and if anything, it would only be accentuated with the addition of an ARPI agent, though we don't have any clear data on that at present. So it may not be that metformin can help mitigate the adverse effect profile of ARPI, but we can be reassured by the fact that the addition of metformin would continue to reduce the side effect profile associated with long-term ADT alone. So I think moving forward, based on the results presented today, we would urge clinicians to consider commencing patients on metformin to help mitigate the side effect profile of ADT in the longer term.